Hi friends, in this topic of general examination, today I will talk about lymphadenopathy. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Lymphadenopathy refers to swelling of the lymph nodes, which can be secondary to bacterial, viral, fungal infections, autoimmune diseases, or malignancy. Generalized lymphadenopathy is the term used when there is involvement of more than two or more non contiguous lymph nodes and it is typically indicative of systemic disease. Non-contiguous lymph nodes mean, as seen in lymphoma, in which lymph nodes containing cancer are not next to each other but are on the same side of the diaphragm. Lymph nodes in the supraclavicular fossa, cervical region, axillary region should be very well palpated, and we should not forget to feel gently behind the sternocleidomastoid muscles. If they are enlarged, they may be secondary to spread of the malignant disease from the chest, and such finding will influence the decision regarding the treatment. Lymph nodes in the neck are best felt by sitting the patient up and examining from the behind. Whenever we examine the lymph node, we have to see the size, shape, its fixity, and consistency. Size of more than 2 centimeter in inguinal region is significant lymphadenopathy, and size if it is more than 1 centimeter in the extrainguinal region, then it is also significant. In inguinal region, if the size is less than 2 centimeter, it is clinically insignificant. Patients who have lymph nodes in the supraclavicular, epitrochlear, popliteal region, or any lymph node with a lesion in the draining area will be significant. Based on the fixity, when they are fixed to each other, we call it as a matted lymph nodes. When they are fixed to underlying tissue, when they are fixed to skin, they are all clinically significant. Hard firm lymph nodes are also clinically significant. Persistent generalized lymphadenopathy is the term used when more than 1 centimeter in size lymph node and in two or more areas persisting for more than 3 or more months. And mnemonic is 1 to 3. It is seen in HIV patients. Causes of generalized lymphadenopathy are infections like bacterial causes are disseminated tuberculosis, secondary syphilis, viral causes are HIV, infectious mononucleosis, parasites which causes generalized lymphadenopathy are toxoplasma, fungal infections like histoplasmosis, coccidomycosis, paracoccidomycosis, they all contribute to generalized lymphadenopathy. Lymphoma, acute leukemia, CML, CLL, they all contribute to generalized lymphadenopathy. Various immunological autoimmune diseases like SLE, adult onset Still's disease, juvenile rheumatoid arthritis, Sjogren's syndrome, Kawasaki disease, serum sickness, they all contribute to generalized lymphadenopathy. Sarcoidosis, amyloidosis, histiocytosis X, and hyperthyroidism, they also cause generalized lymphadenopathy. Besides this, there are certain drugs like phenytoin, primidone, carbamazepine, allopurinol, captopril, cotrimoxazole, sulindac, hydralazine, beta blockers. They also cause generalized lymphadenopathy. Various syndromic lymphadenopathy is seen in Kikuchi Fujimoto disease, Castleman's disease, Kimura disease, Rosai Dorfman syndrome, familial Mediterranean fever, miscellaneous like Niemann-Pick disease. Whenever we describe a lymph node, we have to describe its size, site, number, consistency, overlying skin, mobility, tenderness, and the draining area. The lymph nodes usually are soft, This is a normal consistency. When they are hard, it may suggest malignancy. When they feel like rubber, like Indian rubber, we may think of Hodgkin's lymphoma. Shorty lymph nodes are seen in syphilis. Buboes, a large node with central necrosis, is feature of lymphogranuloma venereum. Matted lymph nodes are seen in tuberculosis due to periadenitis, and hard lymph nodes are seen in tuberculosis, hyperplastic tuberculosis lymphadenopathy. Various type of lymph nodes which are seen are cervical. They can be preauricular, upper cervical, median cervical, supraclavicular, posterior cervical, axillary lymph nodes, mesenteric lymph nodes, inguinal lymph nodes, popliteal lymph nodes, aortic, para-aortic lymph nodes, epitrochlear lymph nodes, mediastinal lymph nodes. Whenever we examine the lymph node, there is a technique which we should follow. Always evaluate for symmetry. Clinically significant nodes classically are asymmetric. Identify salivary glands by location as non-lymph nodes. Identify carotid artery or bulb by pulsation as non-lymph nodes. Supraclavicular fossa is the most significant area and it often indicates a process deep in body. Left supraclavicular node, also called Virchow's node, it is a classical sign of abdominal malignancy. Right supraclavicular node is a classical sign of intrathoracic malignancy. We should always trim our fingernails whenever we are examining the patient for lymph nodes. Infraclavicular fossa nodes, they are classically seen in breast cancer or malignant lymphoma, and epitrochlear lymph nodes, they are best felt when moving finger up and down. Cervical lymph nodes are divided into superficial and deep. Superficial lymph nodes are when they are above cervical fascia, and when they are below cervical fascia, we call them as deep lymph nodes, deep cervical lymph nodes. They can be vertical or horizontal. Superficial cervical lymph nodes are external Waldeyer ring, submental lymph nodes, submandibular bilateral lymph nodes, preauricular bilateral, postauricular lymph nodes, occipital lymph nodes, pretracheal, paratracheal, posterior triangle lymph node. Deep cervical lymph nodes are horizontal groups like supraclavicular lymph nodes and vertical group like jugulodigastric and jugulo-omohyoid lymph nodes. Let's come to the examination of cervical lymph node. Examination of the anterior group of lymph nodes is done by standing behind the patient. We have to flex the neck of the patient to relax the fascia. First, feel for submental group using a single finger, or we can use fingers of the both head also. Then bilateral, submandibular, bilateral preauricular, jugulodigastric, jugulo-omohyoid, and supraclavicular lymph nodes are also palpated. In this picture, we can see how we stand behind the patient and examine submental, submandibular lymph nodes, preauricular lymph nodes. Preauricular lymph nodes are usually in front of the ear. For palpation of the preauricular lymph nodes, we have to roll our fingers in front of the ear against the maxilla. And similarly, anterior cervical lymph nodes or jugular lymph nodes, they lie both on the top or beneath the sternomastoid muscles from the angle of the jaw to the top of clavicle. We have to gently bend the patient's head forward and roll our fingers over the deeper muscles along the carotid arteries. Coming to the examination of the posterior group of cervical lymph node, it is done by standing in front of the patient. We have to feel for the posterior auricular, occipital, posterior triangle group of lymph nodes. Here in the picture we can see the posterior auricular group of lymph nodes behind the ear and superficial to the mastoid process. Posterior auricular lymph nodes are palpated behind the ear on the mastoid process. Let's discuss about the supraclavicular lymph nodes and their drainage. Right supraclavicular lymph nodes, they drain the right lung, all the three lobes, and left lung, lower lobe. And left supraclavicular lymph node drains mainly the left lung, upper lobe, and all the four B's and gonads. Four B's are breast, bronchus, bowel, bladder, and gonads like testes and ovary. Mechanism of the left supraclavicular lymphadenopathy in GI and other malignancies. Reflux of the tumor cells from the thoracic duct into the left supraclavicular lymph node at the junction of the thoracic duct and the left subclavian artery. Few signs which we may confuse that Trozier sign of tetany, it is leads to carbopetal spasm, Trozier's syndrome, it is migratory thrombophlebitis in malignancy, and Trozier sign is the enlarged hard left supraclavicular lymph node. We also call it as a Virchow's node. Other various names for the different lymph nodes are Virchow's node is the left supraclavicular node, Scalene node are the uh, sentinel node of bronchogenic carcinoma, where we have to relax the neck, palpate between the two heads of the sternocleidomastoid. Winter's bottom sign, it is the posterior triangle lymph node enlargement, and it is seen in early phase of African trypanosomiasis. Causes of posterior triangle lymph node enlargement are scalp infections, measles, rubella, infectious mononucleosis, trypanosomiasis. Nodes of Woods are jugular-digastric lymph node seen in TB and they spread by tonsils. Delphian nodes are pretracheal nodes. External Walder ring is commonly seen in non-Hodgkin lymphoma. Berry's nodes are jugulo-omohyoid lymph nodes seen in thyroid malignancy. Coming to axillary group of lymph nodes, there are 5 axillary group of lymph nodes. They include lateral, that is humeral, anterior group of lymph nodes, that is pectoral, posterior, that is subscapular lymph nodes, central, and the apical nodes. The apical nodes are the final common pathway for the all axillary lymph nodes. Means all these lymph nodes they drain into apical lymph nodes. We have to examine the right axillary lymph node with the left hand, except for the lateral group, that is humeral group of lymph node, which is examined with the right hand. In this picture we can see the apical group of lymph nodes, lateral group of lymph node, posterior axillary lymph nodes, anterior axillary lymph nodes, and their position and relation with the different structures. Let's examine the right axillary lymph node. Here we hyperabduct the right arm of the patient. We place the right forearm of the patient on our left forearm. We insinuate our left hand fingertips deep in the axilla of the patient, using our right hand to apply pressure over the patient's shoulder. We have to feel for the apical lymph node using your over hand. Let me talk again. We have to hyperabduct the right arm of the patient. Place the right forearm of the patient on our left forearm. We have to insinuate the left hand fingertips deep into the axilla of the patient, using our right hand to apply the pressure over the patient's shoulder. We have to feel the apical lymph nodes using our left hand. Central group can be felt just below the apical group, and anterior group can be felt on the anterior axillary fold. Posterior group can be felt on the posterior axillary fold. Lateral group is felt with the examiner's right hand, or means over right hand, by palpating over the patient's humerus. The axillary group of lymph nodes, they drain the chest wall with the breast, parietal pleura, and the upper limb. Mnemonic for axillary lymph nodes is apical, A for anterior, P for posterior, I for infraclavicular, C central, A for apical, and lateral. 75% of the lymphatics from the breast drain into axillary lymph node, and remaining to the internal thoracic abdominal nodes or other nodes of the breast. Coming to epitrochlear group of lymph nodes, they are situated on the medial aspect of the elbow, about 4 to 5 cm above the humeral trochlea. Epitrochlear, they drain the lymph from the last 2 or 3 fingers and from the medial aspect of the hand itself. For examining the right elbow, we have to rest the right elbow of the patient on the right hand palm of the examiner and feel the lymph node with the thumb or by placing the 3 fingers. The various causes of epitrochlear lymphadenopathy are secondary syphilis, non-Hodgkin lymphoma, HIV, disseminated tuberculosis, sporotrichosis, and cat scratch disease. The inguinal lymph nodes are horizontal group or vertical group. Horizontal group is palpated along the inguinal ligament, and vertical group is palpated vertically downward from the midpoint of the inguinal ligament towards the course of saphenous vein. Horizontal group that drain the external genitalia, scrotum, perianal region, anal canal below the dentate line, and vertical group they drain the lower limb. Coming to popliteal lymph nodes, we have to palpate the popliteal fossa with the knee in the semi-flexed position. The various systemic diseases which cause the enlargement of the popliteal lymph nodes are non-Hodgkin lymphoma, disseminated tuberculosis, and HIV. Para-aortic lymphadenopathy is also very common. Here we have to relax the abdomen with the two hands placed over the epigastrium. One should feel for the enlarged lymph nodes by deep palpation. The para-aortic lymphadenopathy is seen in lymphoma, testicular malignancy, and tuberculosis. Coming to mesenteric lymph nodes, they are examined along the line. They are basically along the line of the attachment of the mesentery from the right iliac fossa midly towards the umbilicus. Their mesenteric lymphadenopathy is seen in HIV, lymphoma, ulcerative colitis. Similarly, mediastinal lymph nodes are seen along the trachea, bronchus. D spine sign is bronchophony or whispering. Pectoralici heard over the vertebral spine on the back, below the level of tracheal bifurcation, below the fourth thoracic spine in adults. It indicates tracheobronchial lymphadenopathy. Whenever there is tracheobronchial or mediastinal lymphadenopathy, the D spine sign is positive. It is a bronchophony or whispering pectoralici heard over the vertebral spine on the back, below the level of tracheal bifurcation, that is the fourth thoracic spine. Mark Twain has said, "Kindness is a language which the deaf can hear and the blind can see." With this, I conclude my today's topic on lymphadenopathy. Thank you. Keep learning.